It was a lot shorter the second time.
Very good, when I get home, I will.
Yeah. Did you miss this quiz?
Oh, yeah. Yeah, I just told her.
Hi, everybody.
I'm like,
We're just going to go over the announcements and then get started on our PowerPoint. When you're done socializing. I'm just teasing. Oh.
I mean farm.
Farm?
That's what I meant.
Okay, well, Patho, I was going to say is bad, but you should be done with Patho by now. If you're not, we need to talk. Yes, so farm. Any question about farm, you can ask me during the break. Okay, so some announcements. I did get this room across the hall for testing. If you guys want to do, but I can't do it till Tuesday because it's taken on Monday. There's a class in there on Monday. So I could do it Tuesday from 1:30 to 5. I can sit in there. If you don't mind me clicking on getting stuff done on my computer, I'll be happy to proctor, but you have to let me know. You send me an email if you want to do it that day.
Which Tuesday would that be?
That would be the 18th. I can send out an email.
please.
But just, yeah, okay, I'll send out an email saying this is when I can do it. If you want me to proctor it, then you have to get on a list so I know that you're going to be with me. And then we just finished the study guide, Dr. Peters and I did, so she's going to send that out to you guys in the next couple days. She's in Vegas working on it.
Oh, really?
I'm like, Jenny, really? There you go. So should I tell her not to bring the study guide? No, okay.
Only if she had the exam.
There, exactly. And then I sent out an email about the CCNE visit. The CCNE is our accrediting organization. They will be here for quite a few days. And so on the 13th, which is a Thursday, from 3:30 to 4:30, we would like graduate students to come if possible. And we are thinking about having people even telephone in or Skype in if you can't come. So if you're willing to Skype or telephone in, let me know. It's a really bad day.
Yeah.
It is. But they want to see us teach. I'm like, there's nobody here on Thursdays. I mean, that we could teach. So, oh, well, that's an idea. Look at her. Probably not. This is above and beyond your call of duty. Teaching projects. I've got a couple emails about teaching projects. If you look in your syllabus on page, oh yeah, I don't have page numbers, but if you look under teaching project, you need to develop a teaching project related to one of the Healthy People 2020 objectives. The question was, does it have to be? Yes, it does. Hopefully that answers your questions. If not, email me, those of you online. And then just a reminder to read your assignments before you come to class, because what we lecture on is just augmenting what we hope that you've read, okay? And then next week we'll be talking about diabetes, and there's a lot to learn about diabetes. Make sure your brain is ready, because it's we need you sponge-worthy. She's very good. But it's a lot of information that she gives to you, and a lot of it's going to be on your exam. Yes. So she sent me her PowerPoint. So she'll have handouts and everything, but just be sure and ask questions if she lets you either during or at the end, because a lot of the different medicines and stuff will be on the midterm exam. So you'll see that in the study guide. Dr. Peters goes over kind of which ones we're going to ask you about, but you need to know all of them to be prescribers. You won't be able to use Hippocrates for your exam. Okay, so tonight we have Pat Hurlbut. She is a med tech. She's a med tech. She used to work here, actually. She lectured for us. Then she went to another place somewhere in Milwaukee. But she was... Wait. So she was nice enough to come back and do this lecture just to kind of talk about labs, lab values. She's not going to talk about diagnosing or treating patients with different lab values. She's just going to kind of go over what they mean and how you can interpret them. And then after she's done, I'll give you a couple minutes break, 5 minutes. Okay, 10 because the bathrooms are far away. Give you a 10-minute break, and then I'm going to do an anemia lecture, which I just added, because I know people have a lot of questions in primary care about anemia. It's a very basic lecture about microcytic anemia, which you'll figure out what it is when I talk. Then those who didn't do their presentations the week of the blizzard about the cultures, I sent you all an email. If you didn't, then you got to come up and do it tonight. Okay? So here you go. Thank you. Thanks. Okay, like she said, I'm Pat Hurlbut.
I would also like to introduce Jennifer Savage. Jennifer and I used to work together in the lab, and I haven't seen her for a while, so I'm really excited about dinner afterwards. So if I start talking faster, it means I'm hungry. But I really do want to spend time here, and just, I guess my philosophy here is to make sure that you understand kind of why we do what we do in the labs, and maybe open the doors so that you'll feel comfortable contacting the lab people and asking questions. Because so many times we're down in the basement next to the morgue, and it's kind of forgotten down there. Okay? So first of all, what I'd like to do, if you want to have a seat, that's okay. I was going to say, I might use her as a resource if you guys have really tough questions. But I wanted to explain a little bit about laboratorians. And I am a medical technologist, okay? I have a 4-year degree plus a master's degree in medical technology. I did research. I did one of those way back when programs where we did the 24/7 living in the hospital, and they could call you any time of the day or night. They don't really do a lot of those anymore, okay? and it's a good thing. It's not a real good educational model, but you learn a lot. But just like nursing, where you have anywhere from a CNA that has 6 weeks of training and things like this up to NPs and nurse doctorals, you have the same kind of structure in the laboratory. So when people talk about the lab person can be a phlebotomist who might have had on-the-job training. They might have had a certificate, associate degree. There's a medical lab technician who is an associate degree, and they're really trained how to run the lab tests and to be accurate and not make mistakes. But they don't necessarily have the diagnostic stuff behind it. And then there's the med tech, who spends a lot of time also digging into kind of the same level the nurse practitioners are doing. It's a master's level understanding of what those lab results mean, what can cause problems, how to diagnose using the lab results. Now the biggest difference is that when we diagnose, we don't see the patient. I don't really want to see spots. I don't really want to see skin rashes, things like that. I went into the lab, give me blood any day. Okay, and that's truly the difference. It's not good or bad. It's a different way of approaching diagnosis. And that's why we work really well as a team, if you guys understand that piece, because we're truly objective diagnosticians. We don't see the patient. We don't hear what they're telling me. We only see the lab results that can give us clues without knowing all the other piece that can maybe help with the diagnosis. So what I wanted to do tonight was really talk mostly about panels. And let me pull this up here real quick. And Julie, you have this in their system as well, right? Okay. Okay, basically the common lab panels. Why do we perform lab panels? And I wanted to first make sure we all understood what I mean when I say panel, because there are lots of them, but the most common ones, CBC is a panel. When you get that result, you don't get one result, you get a whole bunch of them. Okay, chemistry panels, you'll see a lot of different types, but ultimately we'll talk about why there's different types of chem panels. Urinalysis, a lot of different results, even though it's a dipstick. And then doing the microscopic, it's still a panel of tests. It's a panel of combination of results. Coag panels, you'll see those, PT, PTTs, those. Thyroid panels, T3, T4, TSH. Liver panels, AST, ALTs, GDTs, all of those. Okay? Those are the ones we'll talk about tonight. Okay, panels give you a clue to the overall health. And this is really the answer to the question, why do we need a panel of tests? Why do we not just say, okay, they're diabetic, I want to do a glucose? We usually look at a panel of tests because it tells us the overall health of the body. Usually, there's 12 body systems represented in a panel of tests. In some way or another, if your body is not working well, it's going to show up if you run a CBC, chem screen, urinalysis. Okay, you're going to see something that's not right if the patient is not healthy. If the patient's healthy, on the other hand, like my husband, who's 50 plus years old, that never goes to see a doctor and things like this, and if you did get him to go to the doctor, he'd say, how are you? Fine. Yeah, you'd play the 20 questions thing. You don't have to play 20 questions. You can run a panel and get a general overview of health. Okay, so if he is really healthy and after asking 20 questions he still says nope, everything's fine, you can run this and find out whether or not he's truly fine or not. So it's really a tool for when you have difficult patients Not to say my husband's difficult, but sometimes he is. And that gives you an idea. Okay? Panels help identify patterns of biochemistry. If you think about the thyroid panels in particular, the negative feedback system where you have T3s and T4s in competition with each other. They use each other as elements to make, if you have T3, you can make T4. If you have T4, it can chew itself up to make T3. You need to have a balance. Okay? TSH is the precursor to both of those. So it's the first indicator. Those are things that you can see. Is your body in balance, or is there maybe an overall issue? Panels can also disclose unidentified issues like high liver enzymes if you're looking at a muscle injury. Okay? That makes sense to me. I don't know if it would make sense to a nurse. But if you had high liver enzymes, why would you have high liver enzymes? I'll do the spot quiz here. Why would you have high liver enzymes if you had a muscle injury? What's happening to the tissue? Yeah, the tissue's being broken down. If there was any blood cell damage, if you broke a blood vessel in any way, shape, or form, like a bruise or something like that, now you've got extra bilirubin getting pumped into the system because your body's trying to get rid of the bruises. So we'd see the liver enzymes being high. That doesn't mean they're alcoholic. It doesn't mean they're, trying to be treating themselves, self-treating. It might just mean there was an injury. And it's something for us to look at. Okay, that's not the only reason you have high liver enzymes. Okay. Some of the other things is that a cost factor. For a panel of tests, it's actually cheaper to run the entire panel. And in many cases, the machine, the instruments that we use, will automatically run the panel. A CBC, if you order a hematocrit, okay, when we run it through the machine, it will still run the entire hemogram, whether you want it or not. So we'll have those results sitting in the lab, but you've only asked for the hematocrit, and so ethically, we only give you the hematocrit. Now, what happens if I saw something that was really, really off and bizarre? I'd probably give you a call and verbally say, would you like the rest of this? Hint, hint. Okay? Because if a lab person calls you and says, would you like that? There might be a reason that we're asking you that. Okay? But I can't really start suggesting tests for you unless you want us to. If you call us up and say, hey, this isn't making sense, can we look at others? What tests should I order? We can help with that, but we can't just run tests randomly down in the lab. That's not allowed. Okay? But CBCs, the entire hemogram piece, the hemoglobin, hematocrits, CBCs, white cells, red cells, the size of the cells, all of that is run automatically, and we have those results. So then, let's say you had a 4-year-old, you did a hemoglobin, found out it was kind of low, now I really kind of want to know more about it. Yes, you can call the lab and see if you can add the order. And we don't have to redraw the child. Okay, that's probably good with a 4-year-old. So, okay, sometimes we do. Urinalysis, same thing. You guys have all seen a dipstick. You know what the dipstick does. So if you ask just for a glucose, we'll give you just a glucose. But in reality, we have a tape from the instrument that probably has given us those other results if there was something else that we need to come up with. Now, pregnancy is not on a dipstick. So when you call up and say, okay, can you add a pregnancy test? It depends if I have one more drop of urine. But for the most part, that's something that we have the ability to add. Okay? And it's cheaper because you're getting all of those tests all at once, whether you need it or not. Okay? Chemistry tests generally are ordered individually. And that's because the instrumentation works differently than a CBC machine or a urinalysis machine. Chemistry tests are done on little discs or in little chemical packs, but they're all individual for the unique test that you're ordering. So in a chemistry screen, we're seriously running 12 separate tests or 20 separate tests, but we're doing it all at once, so you have minimal amount of blood that we needed. So if it was a really difficult draw, we can get more out of a chemistry panel than we can if we just order one test at a time. Okay? Common tests, CBCs. I want to just run through a little bit about basic pathophys review. If you probably have all this, but in the meantime, from a lab person's perspective, what is it that we look at when we look at a CBC? Because again, that might help you understand a different way of looking at a diagnosis. Okay, white blood cells, most common piece that we look at for CBCs usually. They're fighting an infection. It's a general value. It doesn't really tell us that much all by itself, does it? What else do you need? If you ran a white cell count and it was high, what else do you need? Yeah, you want the differential, don't you? Because you want to know what kind of white cells, and the white cell count clumps everything together. Okay? It does tell you a little bit more about winning. Okay, the differential is going to be able to tell us whether or not those cells are healthy, normal cells, and you're just fighting an infection, or if you're starting to take cells out of the bone marrow and pumping them in, the immature cells. When you start seeing a lot of those, you know that the body's losing the battle, and antibiotics are probably your best bet. Okay, if they're still mostly mature cells, oftentimes we can say, let the patient keep fighting it, it's okay. Same thing like with lymphocytes versus segmented neutrophils. You can kind of tell if it's a virus or if it's a bacterial infection, right? You know, just by looking at those. Okay, the losing piece are the immature cells. When you start seeing cells that are bands, blasts, those are the ones that start to cause concern. Okay, please know there are a lot of variations of cells in that blood cell, the stem line, from the bone marrow out to the bloodstream. And only the most mature ones are supposed to be in the bloodstream majority of the time. Okay? So if we see anything else, we can kind of track it back to how far immature those cells are as to where the problems might be. Is it a leukemia? Is it something that's creating a lot of one stage of cells? Or if it's just bands, it means we're just kind of pushing out as many cells as we can to fight an infection and we're losing. Okay? Immune cells, overreactions. Anytime you see an increased amount of eosinophils or an increased amount of basophils, they're not really all that common in the first place. 6% eosinophils, 0 to 2% basophils is a normal. If I see 6% basophils, I kind of jump. If I saw 6% eosinophils, I don't think that much about it because that's kind of normal. So you kind of have to know the normal ranges as well. All lab results come with the result and what that lab's current normal range is. Okay? You always have to compare to what that normal range is because that also tells you the machine's calibration. That's what our population in this area is. And we actually tweak those values from the textbook values to what's in our population. If I worked at Children's Hospital, I have different normal ranges than if I work at Freighter. Does that make sense? Okay, because kids' values are a lot different. And kids' values we even break down to like 0 to 1 years old, 2 to 5 years old, 5 to 12 years old, like that. We'll break them down into even smaller segments because different developmental stages have different things. Okay, increased eosinophils, you usually think allergies, right? Okay, eos allergies, easy one. What are basophils? Increased in basophils, if you see a lot of those. It doesn't happen often, right? Basophils generally are a precursor to something that is putting out from the bone marrow that oftentimes is an early sign of cancer. I worked in Aurora Advanced Healthcare out in Menominee Falls, and we had an oncology clinic. And whenever we would see 4% basophils, our doctors immediately started calling upstairs to get a consult. And let's take a look at this a little bit closer. Now, that's not a guarantee. Okay, it can also be a parasite if they've just recently come from Africa and had done mission work or something like that. Basophils are really good at parasites as well. But you have to then start digging deeper to find out because 4% is not normal. And that's something to pay attention to. Okay? Size and shape matter. You said you were going to talk about microcytic anemia, right? Okay, that's one of them. There's about 72 different types of anemia total. Okay, when I went to school, I had to learn all 72, and you had to identify them and things like this. So please ask us. I spent a lot of time studying those stupid cells. It really would be nice to have people ask. Now, I worked at Advanced Healthcare. I worked at Aurora. We used Epic. Okay, most of you are familiar with Epic as lab system and stuff. When you look at the lab results, most often if you look at the charting, you'll never see this kind of information. Okay, you only see the values, the numerical values. And what I want you to do is start thinking about opening up those lab results because there's usually additional information down in the differential that can give you more clues. Okay, so we'll talk about those. Reticulocytes. Reticulocytes is an immature red cell. Okay, we know that, right? Okay, and it's usually saying that the bone marrow is trying to respond to something. There's a red cell shortage. Why do you have red cell shortages? Pardon? A bleeds. Bruising, football is a really big one. Okay. You can have it just because you're anemic. You know, your body is trying to respond to an anemia. But after a while, it won't produce any more reticulocytes. If it's not being effective, you don't have any more of those to put out either. So just kind of be aware that there's phases and different cycles. Okay? We can qualitatively observe them. And we'll say so. If we see reticulocytes, if we see a large number of reticulocytes, they've kind of got a bluish color to them, and we can see them on our regular differential. So if we suspect something, we'll make a comment that, you know, there's fewer moderate reticulocytes. But if you're just looking at the numbers, you might never see them. So I encourage you that if things aren't all making sense, look at the actual report, because the rest of the differential, the descriptive words, will be in there. Okay? And it might be an early indicator. Okay? Qualitatively, we can see them, not a problem. But if we do want to actually monitor a patient, you know, let's say they are an oncology patient and we're trying to get them to grow more red cells and things like this, then you need to use a retic count. Okay? Lab people don't like retic counts because they take a long time and they're really manual and pain intensive. But they're also really important to do, and we know that too. Okay? You don't have to necessarily do everything every single time, but if you're monitoring, you want to keep track with a count. Okay? Platelets, we know about platelets. The larger platelets are the immature ones. They crumble off into little tiny pieces and go into the bloodstream. When you see platelets in the bloodstream, they're usually little tiny crumbly looking things. They look like cookie crumbs. If you see giant platelets in the bloodstream, it means we're pushing out the immature ones. It doesn't mean they grew. It means they never broke apart. You got the whole piece. Okay? Large platelets are immature, and they're oftentimes an indication of a bleeding problem, internal bleeding, if you haven't been able to find a clot. Because think about it, your body's trying to send out more clotting support. And just seeing large platelets is a pretty good indicator there's something that's going on. Okay? The mean platelet volume, if it's increased, is an early warning sign. The MPV, when it's high, is an early warning sign, because the mean platelet volume is how big are those platelets. So even if we didn't say they were giant platelets, if we know the volume of something this big is less than the volume of something this big, the MPV is the first number that can kind of start giving us those indications. Okay? How many of you have ever looked at an MPV before in the same way? Usually you look at the CBCs, and if it says normal, it's normal and you're good, right? Well, let people look at them different. So, okay? Any questions about CBCs and stuff just in general? I can keep going, but I can tell you lots more about CBCs, but this is the overview. Okay, urinalysis then. Let's talk about a urinalysis, because that's the second most common test ordered. Okay, I used to have a medical technologist who had a specialty in urinalysis. So not only did she do the master's level med tech program, then she went on and did another 2 years to get her specialty in urinalysis, which means all she ever did was look at urine. And I just couldn't even imagine that as a lifestyle or a job or anything else. But she was really good as an instructor. She's a little strange, but she was very good as an instructor. And one of her big things is explaining to us all the time, what goes in must come out, and it's a mirror of the body. The reason that she did what she did was because she truly felt that everything that we do in the laboratory is about looking at the overall health of the body. And urinalysis is easier to get than CBCs in most cases. So it's an easy mirror to use, just because the specimen's easier to collect. Okay, two different parts of the urine testing. Macroscopic is the dipstick, okay, and we know that part. You guys have done that, I'm sure. And then the microscopic is the looking in the microscope to see the concentration of different types of crystals, different types of cells. And not all urinalyses need to have a microscopic test. Now, back when I was in med tech school, you had to do the entire thing every single time. And it was very time intensive, and if it was normal on the macroscopic, you knew the microscopic was going to be normal, because if I look at it in the microscope, if everything in the chemical part is working okay, this part's working okay too. We do still have doctors who were trained, back when I was trained, and they will order the full thing every single time, and we kind of go, okay, we'll take our extra time and work on this test. But we know that there's not going to be anything in there. Okay? It really does make sense to do a reflex test. Okay? If you do a macroscopic with reflex, what that does is says if we see anything that gives us a clue that we should do the microscopic, we will. Does that make sense? Let the lab people look at it, and they can tell you pretty much if there's going to be something in the microscopic. So reflex testing is really, really helpful. It's cost effective, and it lets the lab people do their job better. We don't have to waste our time doing, oh, look, there's one epithelial cell, because we know you're not going to do anything with one epithelial cell either. Okay? So, okay, the macroscopic only. Pediatrics most often does macroscopic only, because we know that collecting a clean catch specimen from a 4-year-old probably isn't going to happen either. And so you might have a lot of protein. What do kids do? They like to run around, they bump into things, they've always got extra protein going on, they've got albumin, they've got, you know, little girls have mucus, things like that. It's just, nah. Okay, so they do just the macroscopic, because when you do just the dipstick, you're really looking for early detection of diseases that, for the most part, are in adults. You know, the diabetes and such doesn't happen as often in children, although we want to know if it does, right? So we do that test. We check because we really want to find that it's healthy. We're looking for health. We're not looking for disease. In adults, we're usually looking for disease, and we're happy about health. It's just a different approach. So age does matter. Okay? Cellular issues. If kids are little and they've been fairly healthy their entire life, they don't have gigantic holes punched in their glomeruli in their kidneys because they've had years of abuse and bad diets and things like this. Okay? Med techs also aren't real good about patient care. That's why they keep us down in the next to the morgue, because we tell patients, you know, you've lived this way for 50 years, you're going to have some damage. We know that. Okay? OBs. Okay? The other one that we do macroscopics all the time. What are we watching for in an OB? There's some things you ignore. What are the things you ignore when you do a macroscopic dipstick on an OB? Anybody work in OB? Okay. When you work at OB, you will have protein, almost guaranteed, almost all the time. Okay? You might have white cells. Why would you have white cells if you have this foreign body growing inside your body, and your patient might be trying to say, this is foreign and I know it? It's not uncommon to see white cells, right? So we kind of look at it as a quick check to see whether or not there's something serious to be concerned about. What are we worried about? We're worried about large amounts of protein. We're worried about large amounts of glucose. We're worried about any of the cellular degeneration, making sure that the kidneys are functioning well, because this is an extra load on their body. But if we see 1+ protein, we see 1+ white cells, we go, yep, pregnant. And we kind of ignore it. Okay. That's where having a med tech kind of comes in handy too, because we can also help with what's normal for situations if you don't work with a lot of OB patients and now you have one and you're not sure whether or not this is something to jump on. It's something that med techs can also help with talking to you about. Okay? So then let's just go through the dipstick real quick and some of the tests that are there. A quick review. Glucose should always, always, always be negative. Okay? How many times have you seen a positive glucose though? A lot. Okay. Because we have patients who have spent their entire lives trying to destroy their kidneys by lots of things that we eat and drink, and you know, it's very hard on a kidney. Do we have high blood pressure? Yes. High blood pressure takes all of the stuff that's in your bloodstream and crams it through these little tiny glomeruli in your kidney and punches holes in it. And it's like having wet Kleenex. Your glomeruli, once they're ripped open, it's like trying to put a wet Kleenex and separate out the different layers and put it back together. It just doesn't work. So over time, glucose comes through these big gigantic holes that you've punched in your glomeruli. So over time, we oftentimes develop things that are like diabetes. And we can see it very early in the kidneys because we've punched the holes through and we've given it clues. Okay? Any positive is significant. Now, we might know the patient is diabetic, we might know the patient is hypertensive, but it doesn't mean we should just ignore it. Because it also might mean that the patient was hypertensive and hasn't been diagnosed yet as diabetic, and this might be the beginning of things that we can stop. It's always easier to treat diabetes early stages than it is late stages. So don't take it for granted. Always look at it. Okay, protein appears with any non-clean catch, especially in females, because it's mucus. Protein, mucus is protein, pure and simple. It's skin cells, it's just a fluid that's thicker than average because it's got these proteins that are built up. So clean catch is really the ideal. If you see protein, you want to first of all look and see whether or not it really was a clean catch. And when we tell the patient to do a clean catch, do we always know that they do that once they go in the bathroom? Quite often not. So that's another piece to just kind of reinvestigate and ask a few more questions. Okay? Protein also appears with diseases and conditions that break down tissues. Okay? So I used to see a ton. I worked with a lot of pediatrics. I worked at Children's Hospital for a while, and then I worked in the lab right next to the pediatric department at AAH. So football season comes around. All the kids start going out and working out like mad in August, and then they do their school physicals. And we would get all these little boys that had huge amounts of protein in their system. And it really was whether or not they were exercising excessively and whether or not they were getting beat up when they were out there playing. So as you kind of go through this, you have to make a judgment call and find out and say, maybe we want to recheck this again after football season to see if it's still there. Make sense? Okay. Bacterial walls are also protein. So if the patient does have a bacterial infection somewhere, there's going to be protein. It just makes sense. Okay? You'll see the microscopic as to whether or not there's bacteria present or not, and whether or not it's in the urinary system, or whether it might be a bacterial infection somewhere else in the body that's not coming through the kidneys. So.
Do you see protein too when somebody's like on their period?
Yes, blood is, those are cell walls, and most definitely, and usually you can't even see the protein because it gets covered up by the blood. And even when patients are using tampons, there is still some blood that can come through. So if you don't ask the patient, are you on your menses, and they don't want to say anything, they'll come down to the lab, do this test. It now costs them a lot of money, and we're going to recheck it, and we probably could have avoided the whole thing. So always good idea to ask if they're on their menses or how recent it's been, and ask them to come to the lab in between cycles. It just makes more sense. That's the most accurate value. Okay? Saves a lot of money, and it saves a lot of stress too, because if you tell the patient, now we need a recheck, they start imagining the worst case scenarios, and in reality it might just have been a couple days before or after their menses. Okay? Specific gravity. Specific gravity measures the kidney's ability to concentrate urine. Okay, so this is one of the tests that I always kind of laugh. I heard this great story back when I worked at WCTC for a while. I was teaching lab there, and one of my students had a daughter who had gone to the Olympics in Colorado, or Utah, or whatever it was. And it turns out that Bonnie Blair, that was the year that Bonnie Blair won all of her awards. And really, we weren't paying that much attention to it, but it seemed like they weren't announcing, and we knew they had done all these records, and they were waiting for results and waiting. They were waiting for the drug screens. And that's because Bonnie had won, and Bonnie knew she had won, and her body was so psyched that she couldn't go to the bathroom. And they have to do a drug screen that had to have a 1.010 minimum specific gravity. So she's drinking a lot of water to try and get this test done faster, at which point she diluted it. And so they had to then have her drink a lot of water and wait until your kidneys can concentrate it a little bit so that they could run the test. So the Olympic results were actually held up for about 5 hours because of a lab person saying, nope, we don't know that this is a true urine specimen. But what we do with specific gravity is we do find out several things. We can find out whether or not it's a true specimen, which is why you always get a specific gravity with a drug screen, because we want to know that they haven't played around with stuff. Now, When I used to teach laboratory classes, I used to doctor up specimens, and yes, I do know how to doctor specimens. There's also a magazine called High Times that every single month has a lab section about how to beat the drug test. Okay, first of all, it is not written by lab people. Second of all, most of them are not college graduates. Many of them are not high school graduates. And yeah, okay, it's not a real credible source, but it's amazing how many times they'll come in and do a drug screen and tell you, oh, you know, I had this today. Yeah, I saw that magazine too. Oh, okay. And one of the big things that we can tell when people are trying to cheat a drug screen is they try to dilute it. They'll have water somehow or another. They'll have a packet of water. They'll have packets of liquid to try and beat the test. Okay? Dehydration. What we really want, if you're not trying to beat a drug test, is also to find out whether or not the body is getting dehydrated. When specific gravity is increased, okay, where it's concentrated more, it's because there's not enough urine flowing and the patient's body might be getting dehydrated. This is more important when you're in the hospital and you're testing INOs and trying to make sure that the patient is getting enough fluid in, okay? So you'll see the increase there. This is still all part of the dipstick, though. This is nothing rocket science for lab, okay? Kidney damage, okay? We talked a little bit about the big holes in the glomeruli, in the nephrons, and everything goes through. So that means it's not concentrating. Whenever we have kidney damage, we'll have a very low specific gravity. It might stay below 1.010 because everything just goes right on through. There's nothing to hold it in the kidneys long enough to concentrate it. Okay? Is this helpful? Is this the way you learned it in pathophys? Probably not. So, okay. pH. pH is just a normal process. Your body is normally neutral. Okay. Right after eating, it becomes more basic. Okay. And it's just a quick reminder of the pH scale. 7 is neutral. 6, 7 is neutral. 8, 9 is basic. Okay. Basic is the bigger numbers, the way you always remember it if you have troubles with that. It can also become basic because bacteria have recently eaten. Okay, if you have a bacterial infection, the byproducts from the bacteria are the same kind of effect on your urine. So by itself, a basic pH is kind of a, we have to make sure what's been going on. Okay, if it's a non-fasting specimen, I'm much more likely to say, okay, they just ate. Not a big deal. If it's a fasting specimen and it's a high pH, it kind of tells me maybe something else is going on because that's not as normal. Okay, and it's just a clue. It's not a final answer, but it's a clue. Okay, the real answers are going to be in the microscopic. So if any of those results are positive, we flip it over and do the microscopic automatically if we reflex a test. That's where I said if you make the order for with reflex, if it's negative, we don't have to spend our time doing it. You guys don't have any results of 0 to 1 epithelial cells. All is good. But if we see anything abnormal, if you give us permission, we'll go ahead and do that microscopic and do the next check. And here's where you get the real information about what's going on. So normal cells that you might see in a urine are mucus, epithelial, small amounts of bacteria just because it's not a sterile area. Generally, males don't have that same issue because the proximity, they've got a faster flow and a narrower tube, so they kind of flush out the system, and all that stuff goes away first. So that's why clean catch, you're supposed to pee a little and then catch. Okay. However, if you do a clean catch, you really shouldn't see mucus, cells, crystals, bacteria. Always try to get a female specimen as a clean catch, just to avoid all of the mucus secretions from the vaginal secretions. Okay. Normal lactobacillus is always present. Things like that. Red cells. Don't ask for it when they're on their menses. It's not safe to assume that red cells are from menses. And usually you avoid a few days before and a few days after, like 2 to 3 days before, 2 to 3 days after, because it's just a process. It doesn't turn itself on and turn itself off. The bilirubin is a breakdown of a red cell. So if you see red cells, chances are you're going to see bilirubin too. Make sense? Okay. Okay. Urobilinogen should be resorbed. Okay, if it's not, then that might be an internal bleeding. okay, because that's not from red cells breaking down. It's the further process of red cells breaking down. It's where the liver is not working correctly. And so urobilinogen, when you see that one, anything higher than a 1.0 means there might be some liver involvement. And the liver by itself is cleaning out the rest of the body. So by itself doesn't mean there's liver disease. It just says the liver's working extra hard and overtime. Find out why. Okay? White cells. Inside the urinalysis, you might see white cells with infectious process if somebody has a UTI. One of the rules of thumb in the laboratory is if you've had a UTI once, chances are you're going to get them again. If you've had a yeast infection once, chances are you're going to have them again. If you've never had a yeast infection, chances are you never will. Okay? If you've never had a UTI, chances are you never will. Your body is just structurally different enough that you've been lucky. But there are patients who they know very well, I got a UTI coming on, and they really don't need to go through all this process. They just want to get their meds. You still need to do the dipstick at least to get the white cell count and confirm that, yes, they have an infectious process going on. But most patients will tell you first. Okay. The white cells can be a kidney infection or a bladder infection. It does not necessarily tell you which one. Okay. The bacteria will be present, medium, large quantities is significant. If it's 0 to 1, trace, small, we don't really necessarily know that that's a bacterial infection. It could be a transport process. Patients that know that they have urinary tract infections oftentimes will bring a specimen in with them, and they might leave it in the car. Well, right now, that would kill everything. But in spring or in fall, you leave it in your car for a half an hour, and if it's nice and warm and comfy and happy, it's going to continue to grow bacteria. And by the time it gets to the laboratory, an hour or 2 hours later, those bacteria are very happy, and they've been happily reproducing. And that doesn't mean there's an infection. It just means that it wasn't a clean catch, quickly done after the testing. Same thing can hold true with labs processing, because most laboratories, not most, many lab results will be done on site right away to avoid problems with transport, but occasionally you'll have a lab that the lab tech isn't there for the day, so we'll have to move all the specimens to a different lab. Well, we do everything we can. We refrigerate things, we keep them all in climate control to try and minimize all the changes, but bacteria is one of those indicators that it might just be an old specimen too. Okay, how do I know it's an old specimen? I look at the time it was collected, and I look at the final time of the lab result. And it should be fairly close to each other. Okay? If it's a lot different, if the patient collected it first thing in the morning and I'm now running the test at 1 o'clock in the afternoon, something happened with transportation that might make a reason to question that and get a recheck. Okay? Urinary tract infections usually show both white cells and bacteria. Okay? Not always. We can catch them earlier than that. But most times your body is reacting very quickly to it, and you'll see white cells as well. Okay? If you see 1 or 2, you don't worry about it. If you see a lot of either white cells or bacteria, you do want to make sure you follow up with the patient, get them on antibiotics, get it taken care of. Okay? Proteinuria. This is kind of a tough one because a lot of people get stressed about, and they'll ask a lot of questions about it. This is one that we get a lot of questions in the lab. Whenever we see a lot of protein or albumin in the urinalysis, what does that mean? Okay? For the most part, we have to decide whether or not it came through the glomerulus or whether or not it's an external factor. Okay? If it came through the glomerulus, that means there was a large protein that made it through a hole in that glomerulus, and so there's probably kidney damage. But if it's an external factor where it just wasn't a clean catch, then we aren't worried. So it's really looking at trying to figure out what other things cause those holes in the glomerulus. Most often, chronic kidney disease is a big one, usually resulting from diabetes or hypertension, other issues. Okay, but if they have a diagnosis of CKD, chances are you're always going to see protein in their urine. There's never going to be a time where, even if it's a clean catch, you're still going to see proteins in their urine just because their kidneys are damaged. Okay? It's an early sign of hypertension. We have a lot of undiagnosed hypertension out there. If for some reason their blood pressure is normal, but we're seeing a lot of protein, we might be finding somebody who does an awful lot of caffeine during the day and didn't do it today, so their blood pressure is kind of normal, but on a normal living daily basis, they've got a much higher blood pressure. It might be worth starting to follow up with them and say we've got some early signs to check to see about hypertension. Okay? Glomerulus don't have the ability to repair themselves. Like I said, it's kind of like the wet Kleenex where you want to try and separate them back out and make them nice and neat again. It just doesn't happen. High blood pressure causes that excessive pressure, and that's what leaks all the proteins and the glucose. Crystals. Your body isn't able to filter as well. It's kind of a sluggish, if you think of the deltas down in Louisiana, all the silt that kind of comes down the rivers and ends up on the banks, okay? Crystals are usually a sluggish urine system. And your body isn't filtering as well, so it has time to gather up and start making crystals. Okay, so if you see anything with large quantities, you have to look and see what's causing it. If it's a really large quantity, it might have been because we stuck it in the fridge and the refrigeration makes crystals. Okay, so if a patient brings it from home, if it's out in the cold for any length of time, this time of season and stuff like that. Okay, acidic or alkaline crystals give us another clue, and we have to always correlate them to the pH. We can't have uric acid crystals in an alkaline urine. Acid, uric acid, and alkaline, that doesn't make sense. Okay, so it always has to match, and the lab tech should be following that, making sure. The biggest reason we look at crystals is to find out whether or not the patient has a potential for kidney stones. Okay, if they, and this was kind of a situation that we had a lot. Down in Chicago, we had a lot of kids that, when I lived in Chicago and worked downtown in one of the inner city labs, we had a lot of kids who would not go to the bathroom in a public school, okay, because that's where the problems happened. That's where you got bullied and everything else. So they would hold it all day long. And as a result, 16-year-olds were having kidney stones. And it's like, wow, how can you have kidney stones at 16 years old? Well, it's because they were living in fear, and it was another whole issue. But the reason they were getting kidney stones was because they also weren't drinking water. They were doing everything they could so that they didn't have to go into a dangerous spot. Okay, so it's also just knowing your population, know the people that you're around and what's going on. Okay, some other cells that you'll see on the reports, epithelial cells, skin cells. It's normal to have skin cells come off. It's really not significant if it's less than 10 cells per field. And LPF means low power field. That means on the microscope we're looking at it with the low power, which means we can see a big space. We look at crystals under high power, we look at cells under low power. And that's just because we get a better general idea of how things are looking. Okay? In a clean catch, if we're seeing a lot of epithelial cells, we might start looking a little bit more for trichomonas because there's something that's irritating the skin that the skin is trying to slough off. So it's not a hard and fast rule, but it's something that we'll start looking for. And we'll let you know if we see trichomonas on there. Okay? Tubular or transitional cells. You'll see those occasionally in the reports. And transitional cells, if you think about the layers of the skin, you've got your epithelial cells on the top, and then you've got the columnar and the tubular transitional cells. And so that tells me that we've already gotten rid of the top layer, and now we're digging down into the second and third layers of the skin or the inside linings of the bladder or the kidneys. And if those are coming out, we want to start looking at, is there something wrong with the bladder? Okay, it's kind of like a scrape on the skin outside. That's kind of all for urinalysis. Does that help a little bit? Do you think you look at the urinalysis anymore? It's just go, oh yeah, whatever. There's a lot to it, isn't there? Yes, question.
So when you say you're looking at the bladder, are you thinking things like bladder cancer or somebody that has to self-cath and they're damaging?
Yes. The question is whether or not, why they would be looking at the lining of the bladder and what's causing injury to the inside of the bladder. Most often it's a self-cath. The patients that are in a wheelchair that might need to self-cath, you'll see a lot of those, and what we can do then is talk about techniques and talk about maybe a different model that might work better for them, different size tubing, things like that. Bladder cancers, not so much. We're going to see other cells that we're going to look at, and we would be letting you know about those. So, okay? But that's a very good question. It's usually about catheterized. Okay? Shall we go on to chem panels? So, you guys still with me? I know it's hard. Okay, chemistries. Biochemical reactions. The one thing that I really never understood about biochemistry in high school and college, my first year of college, undergrad college, was that biochemistry is really about hemostasis. It's keeping your body in balance. And once I realized that, everything else made sense. But they never made that connection in the pure sciences. They made that connection in med tech school. But biochemistry is really about keeping your normal healthy balance, normal healthy lifestyle. So things do vary a lot based on diet. What if you're a vegan and there's a lot of things that you don't eat? Does that affect your biochemistry? Yes, but that's not necessarily bad. It's just, it will affect it, and you have to know how, okay? I have one friend whose son has Duchenne's muscular dystrophy, and he will only eat noodles, okay? Is that a healthy diet for anybody? After 26 years, she still can't get him to eat anything except noodles, though. And as a result, his chemistries are way, way off because he does not have a balanced diet and he doesn't have the things that he could use to probably benefit his body. Now, I've been told that there are things with Duchenne's that actually make patients crave the carbohydrates in a different way than vegetables and stuff. And if you can't get somebody to eat vegetables, I guess you can't get them to eat vegetables. But wow, you just know as a biochemist that vegetables have a lot of things that would probably help a lot of other processes in making cells that would heal. So, okay. So some of the other things we're going to look at are glucose, triglycerides, liver enzymes, all those good things, cholesterols. We also do have much more narrow ranges that are not diet related. They're process related. They're end products, okay? So some things that we have to know about fasting levels, glucoses, triglycerides, are big, big diet change. Every 5 hours it goes up or down or whatever, and that's why we ask for fasting specimens. But there's other things like creatinine and BUN that are the end products of chemistry, biochemical cycles, and they're very stable. And so those will tell us how the rest of the body is doing. Does that make sense? Okay. Let's start with glucose because that's kind of the most common one. The body system's affected. Just for starters, GI, thyroid, brain function, hormonal production, and GU. 5 systems in one. If the glucose is off, it's affecting 5 other places. We know that. Okay? Now, how badly is it affecting your brain function? Well, if glucose is really, really low, glucose is the only thing that can cross the blood-brain barrier to feed your brain. So if you have a hypoglycemic episode, you tend to go comatose because your body is saying, I can't handle this, I'm starving. Okay, it's brain food. And so if it's really, really high, what happens? Well, what happens when you have a big Thanksgiving dinner? Your brain kind of goes on overload and says, oh my gosh, I really can't handle this, and usually shuts down because it's just an overwhelm. Okay? When you come to glucose itself, it's the simplest sugar, but there are other sugars. There are a lot of other sugars. Fructose, galactose, maltose, dextrose, you've heard of all of those, and those are also in foods. But all of those get broken down into glucose. Okay? In your body, it will always break down into glucose. We've had patients with diabetic education that have come into us and talked about, well, I am doing everything I can not to eat glucose. And yet they don't understand that we had one patient who really didn't understand that a Frosty at Wendy's was not sugar. And it's because it didn't say it was. And so, sometimes you just can't make the assumptions that patients understand what that really means. They were eating lots and lots of fruits and vegetables, but while they were really eating all fruits, they weren't eating vegetables, at which point they're messing with their glucoses. Okay? So making sure that they understand what glucose is and that it's a breakdown product of all those other sugars that are out there too. And the carbs. Starchy foods break down into glucose. So any carbs are going to screw up your glucoses. So that's part of it. HCFS, what is it? Fructose. It's the corn syrup product. I can't think of what Pardon?
Just the high fructose corn syrup?
Yeah, high fructose corn syrup. I've got it reversed. HFCS. That's why it's like I'm drawing a blank as to what that stands for. That is like one of the worst evils in the world. We really do have to stop putting that in all of our foods. It's really not healthy. There's nothing good about it, and it is creating diabetes in the long term. We are just now starting to set rules and regulations to get that out of some of the foods and the diets and stuff, but we've put it into so many things because it was cheap and it was easy to produce. It really is nothing nutritionally good for you. Okay? When the body does have liver damage, it can't break down the fats, can't break down carbs. As a result, you're going to have pancreatic damage because it's not getting the parts that it needs to make your pancreas healthy, and it can't produce insulin. So when you do have diabetes, it's kind of this vicious cycle, because when your liver and your pancreas aren't functioning right, you end up with extra glucose and the inability to break it down. And so it just continues the cycle. So the patient can become brittle diabetic as patients go with diabetes, and I'm sure you'll have that different lecture, talking about diabetes. Okay? When the brain doesn't get enough food, the thyroid and the pituitary issues also come up. Okay? So when your patient is not controlling their diabetes, the long-term effects where the thyroid and the pancreas come in, or the thyroid and the pituitary come in, are that your thyroid and pituitary are starving and they stop producing, because when you don't have enough food, you stop working. Okay? Just like human does. Okay? Imbalances of other hormones can be secondary to glucoses. So always look at your glucoses first, see if you can get those in control, and oftentimes other things will resolve. The next question then is about the H1C. There are a lot of different names for glycosylated hemoglobin. HA1C, HbA1c, A1Cs, whatever you want to call it. But basically, HB is hemoglobin. Okay, so the glycosylated hemoglobins. Where is hemoglobin located? Inside your red blood cells. Okay, so a glycosylated hemoglobin means that there's a molecule inside the red cell that's getting extra glucoses stuck to it. And think of it as being very sticky. And so over time, your red cells are going to live for about 120 days. 3 to 4 months, we're going to be able to tell how much glucose you took in. So if you're really, really good at manipulating the system, where you only eat, really good for those last 3 days before you come in to see the doctor, this test is going to bust you, because all of those other days have taken that glucose and stuck it to the hemoglobin cells inside your red cells. And the hemoglobin A1C is a better measure over time, because we take it over the average of 3 to 4 months. So, okay? It's a more expensive test to run. That's why we don't run it in a normal everyday screen, but it's a very, very valuable test, because it tells you a lot more about how well the patient is staying in compliance. Okay? Okay, if the A1Cs, chances are glucose has been high overall. It may be good today, but it's been high overall. It is a better indicator for diabetic control. The formula, the magic formula, is 28.7, magic number, 28.7 times the A1C minus 46.7 is your average glucose. So you can kind of reverse this formula. If you know what your A1C value is, you can do kind of an estimate of what their average glucose was. So even though their glucose today is 56, their average might be 120. 120 times 28.7 minus 46.7 is the magic formula. You can go back and prove to them, no, you've been high a lot more than you've been normal. Okay? It's a good formula to know. Okay. The other one that's a really good combination formula that people may or may not understand, and if patients understand this, we would get a lot further in life too about controlling cholesterol. But cholesterol, your total cholesterol, is a combination of a whole bunch of little things. It's triglycerides divided by 5, plus HDL, plus LDL, plus VLDL, plus chylomicrons. Okay, so what are those things? We normally measure total cholesterol, and we normally measure triglycerides. It's divided by 5 because your normal diet cycle, if you think about fasting, is 5 hours. Okay? It goes back to normal after 5 hours. So triglyceride over 5 tells us your average triglyceride, whether you've just eaten or not eaten. The HDL is high-density lipoproteins, and those are the ones that are really well packed. It took a lot of energy from your body to make them packed into a condensed form, high density, and those are the good ones. Because if you think about a suitcase and you package everything up and you fold up your clothes nice and neat, you can get a whole lot more into it than if you just throw all your clothes into a suitcase and try and shut it. Make sense? Where's cholesterol used in your bloodstream or in your body? I kind of gave it away. Cholesterol holds your blood cells, your blood vessels open. Okay? It's the lining of all of your blood vessels. So if you have a lot of cholesterol, what does it do? It packs high-density ones, very nice and neat, around the outside, and it keeps the integrity of your blood vessels really strong. If you have low-density lipoproteins, you've just taken everything and just thrown it into those vessels. Now those are harder to get the blood through because you never bothered taking the energy to pack it, condense it around the outside of the lumen. Okay? So high density takes energy to make the good cholesterol. Now we've talked about cholesterol, triglycerides that are just in the bloodstream that are getting processed before they become high density. Okay, triglycerides are the first product. We can break it down, make it packed into high density, or we can throw it in as low density. But there's also very low density. What does that tell you? It tells you we didn't even do the laundry. Okay, when we packed our suitcase, we threw everything in. And then there's chylomicrons. Chylomicrons are fats that float on top of this blood. Okay, when we're in the laboratory, when we spin down blood cells, our blood specimens, we'll have the red cells down at the bottom, the platelets and such, and white cells, and then we'll also have the serum. Up on top of the serum, when you have a lot of fat that is not being processed at all, that's chylomicrons. They're just visual. We can't even measure them because they don't stay in the blood. They float on top. They're horrible. Okay? If you eat a Frosty every single day, I guarantee you will have chylomicrons floating on the top of your blood. Guaranteed. Okay? So, triglycerides are high. If the triglycerides are still high after you've been fasting, chances are this is an issue with your liver function because your liver is the one that's doing the energy that's starting to pack those high-density lipoproteins. And if you've got a lot of those initial products that aren't getting packed down, it means there might be an issue with your liver function. That's the place to start. Okay? A true fast. I do want to talk about this just because this is a med tech in me. I really want people to understand what a true fast really means. A 12-hour fast, no alcohol for 3 days prior to testing. Why? Okay? It takes about 12 hours to process those fats all the way through. So if you really want to get a nice, true baseline, you don't fast for just 5 hours, you fast for 12. That's why we usually have patients come in first thing in the morning because then they've been sleeping all night and they don't mind fasting for 12 hours. Okay? If you've got somebody who works third shift, have them fast from the time they go, get home to the time they come in so that it's while they're sleeping and they don't mind fasting. The 3 days prior to testing for alcohol, though, is the kicker. One of the worst things that can happen that's really common is we have a lot of patients who come in the day after Christmas because that was the holiday, right? And they had alcohol the day before that or whatever, and their cholesterols are now high, and they're going, oh man, I know. Well, if we knew back in that formula, that the total cholesterol is a factor of that triglyceride over 5, and we haven't processed it all yet for the next 3 days, of course it's going to be a high cholesterol. Of course it's going to be a high triglyceride, but we generally forget to tell patients about that 3 days of alcohol. We just try to get the 5-hour fast. Okay? The worst time to come in to the lab is the day after a holiday because chances are you've been eating really terribly, you might have had that alcohol, and now you're going to try and get a really accurate lab result. So, okay? Cholesterol is essential for those linings of the blood vessels. One of the things that I also do want to make sure that people understand, though, is that cholesterol comes from anything that has its own liver. The liver produces cholesterol. Okay? So what kind of foods have cholesterol? Meats, right? Eggs. Came from a chicken, had a liver. Okay? Anything that comes from an animal that has its own liver, including humans, Okay? We can make our own cholesterol. We don't need to get it from our diet. Our body will make it because we have a liver. Okay? So since cholesterol is made from your diet, vegetarians make their own cholesterol just fine. You don't have to worry about supplementing cholesterol ever. Okay? It's just fine. Fair enough? It's a good rule to know when patients are trying to cut down on, or reduce their cholesterol, that if it's got a liver, it's got cholesterol. What do you think about potato chips that say no cholesterol, cholesterol free? What's that telling you? Yeah, potato chips aren't made from an animal, right? So did we know that? Probably. What it is saying is that we're not using animal oils, we're using vegetable oils or whatever. That does not make potato chips healthy, but it sounds good in the ad, doesn't it? Oh, this is cholesterol free. Okay, I can call a lot of things free of food. Just a side note here, Doritos. I love Doritos, okay? Please understand that I love Doritos. However, there is no healthy benefit to a Dorito whatsoever. They had to add cheese to Doritos to call it a food because it didn't meet the standards of the FDA. You can't call it a food product because there wasn't enough food in it until they added cheese. Okay? When you look at it under the microscope, you'll probably change your mind about ever eating them. I've gotten way past that. But Doritos taste good, but they're not really food. Okay? Let's go on to liver enzymes. AST, ALT, GGTs, bilirubins. Okay, those are kind of the four that get clumped together most often. Okay, and bilirubin is a byproduct, so just keep that in mind too. The liver produces multiple enzymes to break down tissues that were digested, but you'll also see the byproducts of that liver breakdown, of the other enzymes. So sometimes the increase of liver enzymes occurs when the body's pushed by a disease, like hepatitis, mono, alcoholism, traumatic tissue injuries, all of those kind of things. The liver's working overtime trying to get rid of stuff, so the enzymes go up. Does that make sense? It's kind of, they've got more stuff coming in, so they start pushing out more stuff. The key is that you recognize when those liver enzymes should be going back down. So we do a follow-up. If we have a high liver enzyme, double check it, go back and check again. And it can be a short time or a long time, depending on what you think might be the disease process, or if you think it's just kind of, oops, we had our alcohol at Christmas and now we have high liver enzymes. Okay? ALT, AST generally rise at about the same time. Okay? And they go pretty fast, but ALT, okay, easy way to remember, L is longer. ALT takes longer to return back to normal. So you might see an ALT slightly elevated, but AST is back to normal. AST is the shorter one. Okay? It's just a process. Okay? It's getting rid of all those excess pieces that are in the body, and the liver cleans out the bloodstream. Okay? If both ALT and AST are decreased, think about vitamin B6 deficiency. That's about the only thing that causes them to be low, because really they can get pretty low and be normal. Okay? Bilirubin is the byproduct of recycling red cells. Okay, whenever a red cell breaks down, we've got iron inside that red cell. And that's another thing. It's sort of like glucose. Your body tries to conserve it because it's something that comes from outside the body. And so we try to recycle whenever we can. Okay, so when the red cells are old, they get destroyed. Bilirubin is one of the byproducts. Anything that causes an increase in destruction of red cells causes an increase in bilirubin. Babies, why do they have high bilirubins? They were just born. What red cells are they getting rid of? Their moms, okay? Because they just kind of went through a traumatic incident, didn't they? So the bilirubins are high. And their liver isn't really working up to capacity yet. So it's trying, but the liver and the lungs are the two last things to develop, and the immune system. But liver and lungs are the two that immediately before birth. So if you're looking at how well the baby is matured and whether or not the baby's ready to be home or not, you're looking at that bilirubin level. And one of the problems that we have is that when you have a lot of bilirubin and your body doesn't know what else to do with it, it oftentimes gets stored in the brain area. And unfortunately, you have this skull that holds everything in, so there can be increased pressures, there can be other damages, and that's why you don't want to have high bilirubins. Okay? Liver disease does increase the billy levels. Things like alcoholism, mono, those can all cause problems, and they can be long-term. My husband had mono back when he was in college, and if he has a drink, he will have high liver enzymes for a couple of days, longer than anybody else, because his liver has never really totally recovered from mono 30 plus years ago, okay? So it may not be a current injury, it may not be a current situation, it may be something from a long time ago too, that your liver is just not working up to capacity anymore. And he had mono pretty badly. Okay? Total proteins. The total proteins in the body are anything that has a cellular structure. So skin cells, red cells, white cells, bacteria cells, anything that has a cellular structure is a protein. Okay? The membranes themselves are made up of biphospholipid layer, and that's a protein. Okay? Excessive cells from things like autoimmune diseases, where your body is trying to break down your other tissues, can cause an increase in total proteins. Cancers, traumatic injuries can all also cause total protein increases. And then the other time that you will see decreases in total proteins is usually with burns. If you have a burn patient, you will see a very, very low protein value. Why? And it's oftentimes an external injury, and it's not going through the bloodstream, it's being sloughed off externally. Okay? So, okay, it can also be overhydration if you've got a patient that's on parenterals, and it can be malnourishment. You'll see that too, like with anorexics. You'll see very funky proteins. Okay? Lipase and amylase, these kind of come as a set. Lipase and amylase are the first signs of pancreatic malfunctions. Okay? They aren't really good indicators of pancreatic problems, but they are one of the first signs. One of the reasons that pancreatic cancer is so difficult to diagnose is because it mimics a lot of other things, and there aren't any real good early indicators. This is about the best you can get for an early indicator for pancreatic issues. Okay? We're still working on other lab tests. I work over at the other school right now, and I just watched a senior presentation that they're doing some patentable work on finding an earlier indicator for pancreatic cancers, but it's not available yet. Okay? So just know that we're working on it. Okay? Albumins. Okay, just like in the urine, albumin, very similar situation here. Albumin here in the bloodstream is a very neutral, stable protein though. Okay? In urine, it can be external, it can be proteinurias, it can be bacteria, things like that. In the bloodstream, albumin is just really a byproduct, and it's very, very stable. So we measure it mostly for total body volume. Okay? We look to see for dehydration, as opposed to looking for a problem that would break up proteins. We look more for what's the total protein compared to the total liquid in the body. And it's one of the first signs of dehydration. So, okay. The GU system, BUNs and creates. Remember how I said originally chemistry panels cover all 12 body systems? Well, here's genitourinary system, BUN and creates. They're usually the backups in the blood system. They should be filtered out. They should just continually be flowing through your body. And if BUN and creat are storing up in your bloodstream, it means there's something blocking the passageway. So getting it out into the GU system is usually the biggest issue. You're looking at kidney damage. You might have also seen it on the urinalysis, but maybe not. You know, it just depends. Okay. You also see decreased values of BUN and creat when you have overhydration, and again, you're looking at ins and outs in inpatient care. Creatinine is useful for screening, but it's really, if it's a known kidney impairment, it really doesn't do much good. What we use creatinines for most nowadays is to measure for MRIs and for radiology procedures that use dyes, because we want to make sure that that dye can be filtered out of the system after the patient had the procedure done. So they will not run certain tests if your creatinines are very, very elevated. Okay, and that's because they know that the kidney function won't get the dye back out of the bloodstream. Okay. Uric acids. Uric acid is formed by the breakdown of some of the amino acids. Okay, what are the amino acids? Tell me where you get amino acids in your blood, in your diet. Where do you get an amino acid? They can be from proteins. Where else? There's a really easy one. We add them as supplements to breakfast cereals and things like that. Okay, we do. Isn't that weird? Okay, but if you don't eat a lot of cereal, maybe you don't know that. But a lot of times the General Mills fortified with, they will start listing all of the amino acids that they're fortified with. We tend to add them to foods. Okay, do we need to? In America, probably not so much. We don't really have dietary issues where we have lack of amino acids. But doesn't it sound good when your cereal is fortified? Going to make you start reading labels more too. Okay. Whenever you have high levels of uric acid, the thing that we worry about most is crystals. Okay. Patients who have diabetes, who now are trying to eat healthy, oftentimes will eat what for breakfast? Breakfast cereals, okay? And they can actually complicate their issues. Try to get them to eat healthy breakfast, not necessarily General Mills breakfast, okay? Because crystals form, and you see it in all the joint fluids. Those uric acid crystals can get sluggish inside the joints, and that's where you have the joint pain. You can have actual joint injuries, and it starts with problems in the feet and works its way up. Okay. The other thing that you can see uric acids in is some chemotherapies, and aspirin can also cause it, but usually like patients with chemos will oftentimes be monitoring their uric acids very closely because it's a very fine line. We are poisoning their body, we know it, and that uric acid can tell us whether or not the dose is too high or too low. Okay. Electrolytes, sodium, potassium, calcium. I know everybody thinks of electrolytes as sodium, potassium, but calcium is there too, okay? And it's there for a reason, because calcium is the stabilizing substance. If we just had to live on sodium, potassium, we'd be up and down all the time. And calcium kind of says, okay, everybody's calm down. And so calcium is just as important to electrolytes as sodium, potassium. Sodium's acidic. That means it has the extra positive charges and it wants to grab other molecules. Potassium is also acidic. A lot of times people try to say, well, they're opposites. Well, they kind of are, but kind of not. Okay? They're both acidic, and they both have positive charges, and they work on different molecules. So don't think of them as opposites like in, they're not like thyroids, or they're not like hormones. They're both positives, and calcium helps keep everything stable. Electrolyte imbalances are another entire lecture. I'm not going to get into all of those, but they really truly can be one of the toughest things to control, in acidosis, alkalosis. Cardiac functions, troponin, CK, LDHs. Troponin is really a newer test in that it's only been around for like the last 20 years, but it's the more accurate test. If you have doctors who have been trained much older, they oftentimes will order the CK, LDHs still. Particularly if they're not dealing with emergency care all the time. But troponins really are myocardial infarction. We're looking to see whether or not there's a heart attack or any heart damage going on right now. Okay? It's a stat test. We really don't order routine troponins. We order them stat all the time. Because if the doctor thinks there might be a problem, or the nurse practitioner thinks there might be a problem, we need to know now and get them in as quick as we can. CKs and LDHs are secondary because they take time to elevate. And so troponin is a faster test, earlier indicator, and CK-LDH will confirm that, yes, maybe there was a problem yesterday. Have you ever had the patient that comes in today because yesterday she had heart issues, she was having chest pain and all that, and didn't want to bother anybody yesterday, so waited till today? So at that point, you might want to do the CK-LDHs because that's going to be a better indicator there. Okay? These are all still part of your chem panel. These are things that we just look at routinely on every single patient every single day. Okay? LDs. We're also looking at MIs, but one of the other things just to kind of keep in the back of your head is LDH does have other sources. It's not just heart. So it could be pulmonary infarctions. It can be cerebral damage. We have MB, BBs. There are other elements, isoenzymes that we can look at. So if you're looking at LDHs and CKs, you might get other fractions that give us other indicators too. But those aren't necessarily done on a screening test. Okay, calcium, we measure it for a lot of things. We just talked about it being the balance for electrolytes in your electrolyte system, but it's also vitamin dietary intake. How many of you get enough calcium every single day? Good job. Okay, how many of you know you're supposed to get enough calcium every single day? It's one of those things, isn't it? It's something that we have trained ourselves to kind of ignore. And most times our body's going to be able to get it out of the bones, get it out of other foods. Yeah, we'll find ways to scavenge it, but every time we scavenge calcium out of a bone, what are we really doing to the bones? We're making them weaker. And it's not an overnight process. It's over time. There's a lot of calcium in bones. We can scavenge for a long time. And the bloodstream is not going to measure what's in your bone. The bloodstream is going to measure what's available today. Okay? So just because you have a calcium level that's normal does not mean that you're not eating away at your bones. If you have a low calcium, it may be an indicator that we don't have anything left to scavenge. Okay, so that's where we start looking at skeletal system in that 12 body systems. Okay, it can also look at bone metastases where things just are not being built correctly in the bone structure. It can also be thyroid, parathyroids. Those also have a lot to do with calcium and balance. Okay, hormonal indicators are balance. And calcium, beta blockers, things like that for heart circulatory system. And just a final note, biochemistry is all about how the body uses what we put into it. Okay? So if we have normal healthy amounts in the bloodstream, we should be a fairly normal healthy adult. If we don't have normal healthy balances in the bloodstream, it just tells us we have to look further. Fair enough? That's why we do panels. Any questions?
Oh, I got a question.
Sure.
All right. Quick question. Today in clinicals, my preceptor had me look at, and we were looking at cholesterol.
Okay.
And she was like, the non-HDL is supposed to be how many points higher than the LDL or lower than?
She's making it hard.
I was like,
If you go back to that formula, really big, broad paintbrush strokes, okay? Cholesterol should be 100 plus your age. Okay, that would be a good paintbrush stroke. Okay, 100 plus your age. So if I'm 150, means I should be about 50 years old. If I'm a kid, 100 plus 10 is, should be 110. Okay, if your cholesterol is really, really high, look at your triglyceride, divide it by 5, and then HDL should be over half of that. It should be 2/3 of that. In reality, it's not. So when you ask for ranges of numbers, it kind of depends which range you started with. So we look at it from a whole different side of things. We look at what's your total, should be 100 plus your age. By the way, what's the rule? You guys probably have learned 200 or less than 200 is good. That means everybody under 100 years old should be fine, right? That's not really where you want to be, but realistically, that's probably where our population is. Okay. So that 100 plus your age is a better indicator than trying to figure out what your LDL is. And really, HDL should be, the way the risk factors come out, it's 5 times, HDL times 5. I'm trying to think exactly how it's phrased. You have 5 times the risk if your HDL is low. So if your HDL is 100, you are at very, very low risk because 200 divided by 100 is only like a 2. So it's kind of going backwards from the formula. It's not, I don't remember exactly how you get to the LDL values, but it is a calculation. Do you remember the formula for?
Have a ratio that you can
Yeah.
see on there that will tell you
Yeah.
these factors.
Yeah, and the ratio is what you worry about. But the LDL, having a lot of LDL just says you haven't bothered packing your bags.
okay.
So no matter what you have in the way of LDL, you should be trying to get more HDL. And how many of you know what your HDL is? Do you guys know what your values are? Okay, I can pretty much tell you what mine are. And this is kind of one of those things that's different. I can't always tell you what my blood pressure is, but I can tell you what my HDLs are. Okay, because I'm a lab person. I like those numbers. But when you come down to the HDLs and the LDLs, good cholesterol, bad cholesterol, you should have more good than bad. And in reality, most of the American population is reversed. So, and there is a formula, but I don't remember. Do you? For LDL, LDL calculated.
We look at, and we have 2 nights of cardiac lecture, and
Okay.
let's go over.
Okay,
The right.
you'll get it then.
So,
I have another one.
Sure.
SAD rate. What is
Oh,
it?
it's the biggest waste of money you can possibly have.
But we keep ordering.
You want my real opinion?
What is it? I mean, I keep
Okay,
ordering it, but I don't know what it is.
a SED rate is a test that I think should be banned from the world. Don't you agree? It's got very, very little value in reality. But some doctors really hold on to it because basically what a SED rate is in the laboratory, we take a lavender top tube, we mix it up really, really good, we pipette it into a long, skinny tube, and then we let it sit to see how long it takes for the cells to settle. Okay? And in an hour, 1 full hour, we see how much that blood is settled. Now, think about cells without a lot of protein on them. Proteins are sticky. Remember those glycosylated hemoglobins where everything's sticky? Okay, same thing with proteins in your bloodstream, in the serum. If there's a lot of protein, it'll stick the red cells together. And then it's kind of like a snowstorm. If you've got lots of little tiny snowflakes, they kind of come down nice and casual and stuff, as opposed to lake effect snow where it's like these big clumps that fall. Okay, same kind of thing. If you don't have a lot of proteins to stick all the red cells together, the red cells just kind of fall very slowly, and you might get a 0 to 10 normal range after an hour. If they've got a lot of protein, they drop, okay, and you get very high numbers. Now, all that really tells me is you got protein. Okay, what's that protein from? What created it? What's causing it? And oh, by the way, the other thing that you can do, if you've ever had a lab test that sits on a countertop that's supposed to be letting, just leave it alone for an hour. I've seen labs, I've done CLIA inspections and stuff. I've gone into laboratories where they put this test off to the side because you don't want to bother it. You want to let it sit for an hour all by its lonesome. So you put it off to the side, like next to the centrifuge. Vibrates the whole counter. And kind of defeats the whole purpose. So it is a very inaccurate test. It tells you have protein. And we knew we had protein anyway. So it is a very, very useless test.
Your receptor Y.
No,
Yeah.
I wasn't there. I was too busy. That's why I figured I'd ask somebody.
Yeah,
Yeah,
it's
some people use it as a inflammatory marker, but it's
Yeah.
not the most accurate.
Yeah, because when you have an inflammation process, you will have autoimmune diseases will all have higher proteins.
That's what she was. That's
Yep.
what the person. I
But
know
that's-
what we were doing it for.
But that's not, and just by the way, it's not an indicator of more is better or more is worse. It just says there's protein. So it's not something that you can monitor of, oh, this week it's 50, last week it was 110. That doesn't really work that way.
So did you do a CRP or something?
Yes. Yes, there are a lot more accurate tests out there. So
Ferritin, like when they have like RBC low or something.
doing a ferritin test is a question. It's not a panel test. It's one that's more specific because now you're trying to figure out, is it an IDA or, what are the precursors? Are they all there or are they missing? So yes, when you're trying to figure out what types of an anemia are present, a ferritin test is a very good test. It'll help you diagnose, but it's more of a diagnostic test than a screen.
Yes, this might be just not thinking straight, but so if you have a low
the end of the day.
protein and you do a SED rate, and your SED rate is good, and your SED rate is going to be low because you have low protein, right? Or is that?
Well, your SED rate, the normal ranges for SED rates are like usually 0 to 10 and 0 to 20 for a female, because they might be on their menses. So 0 to 10 for males, 0 to 20 for females. So there is no such thing as a low. So it might have been low, but it just means that it's not going to drop. So
So
there is no real low sed rate because the normal range can go all the way to 0.
Right.
So, yeah, it
Would it
is.
be on the lower end, would it be on the lower end of the low?
But again, it's not something where you can measure quantitatively at all. It is just a, yep, there's protein. And it's the test that's been done for forever. You know, doctors have used it for forever, and nobody's ever asked them, why do you do this? So go and ask them why. Because there are better tests out there. And, you know, when it comes to understanding sed rates, I think a lot of doctors do think that more is better or more is worse, and that they're measuring. And quantitatively, that's just not the case. There is no rhyme or reason for that. So the one thing I do hope you get out of this is that if you have a lab result that's kind of funky, please call the lab too, because, you know, and realize that, you know, ask for lab managers or lab supervisor or something, because they have a med tech, okay? They have the 4-year degree that should have some of the background to diagnose. If you call just to the lab, you may or may not get somebody who's got that diagnostic skill. It's kind of like asking a CNA, you know, but if you also understand, and I don't want to diminish MLTs at all, because MLTs are the backbone of our labs, but they don't have that diagnostic ability. If you have something that's puzzling you, please call the lab and ask for a med tech, because they can usually help you at least talk it through and stuff too. So, yeah.
Going back to the lipid.
Sure.
piece,
Lipids.
The chylomicrons,
Mhm.
is that report, I don't even know that I've noticed that.
They're really not that
You don't-
they're really not that common. The place that we see them most often is if we've refrigerated a whole bunch of bloods overnight and now we're running a batch of them, and you've got this stuff floating on top. It's not going to be measured, and we really don't report it out, but we can see them. You know, we can almost guarantee that cholesterol is high by looking at it, and it's just saying that really their body is not. You won't get chylomicrons if you have a high HDL. If you have a low HDL and you have a lot of LDL, you might have more VLDLs, you might have chylomicrons. That's just kind of telling us the severity of the cholesterol disease.
So you will indirectly get information about it, even though it's not reported, but through your VLDLs and your...
Through your VLDLs and through your LDLs and such, yes. Yeah. It's not a measurable substance. It's just sitting there floating on top. It always kind of reminds me, if you've ever tried to rinse out an ice cream carton after you've finished the ice cream, the stuff that floats on the top of the water in your sink, okay, that's a chylomicron. Which also tells you something about ice cream, and I like ice cream too. I do actually eat a very healthy diet, but you kind of have to go through, just like you do with anatomy, when you start reading about all the diseases and, oh, I know somebody who's got that, and I've got somebody who's got that. When you start really understanding your dietary impact on biochemistry, you do start paying a lot more attention. And I think so much of what we don't do in healthcare right now, and what we don't do in the general public, if you read Good Housekeeping magazine, you only get a non-healthcare professional's opinion about what the latest trend is. You don't really get the biochemistry behind it. Does it make sense? This newest diet or whatever that they've got, is it going to be good for your body if you take this out, or if you add this, or if you only eat this, or all of these different things? You really need to look at the biochemistry of it to decide whether or not it's a good diet. And that's a nutritionist's job, and registered dietitian's job will help you with those kind of things. So use your allied health people. They want to help. Any other questions? Julie, I'll hand it over to you.
Thank you so much.
I hope this was helpful, and I hope it's just a different perspective. We're not all real ogres downstairs in the basement. And we do like daylight. We really do. I now have a job where I have a window. This is so cool. But I had to leave the lab to get a window. So. Thank you, guys.
If we can come back around 20 after, you don't need to go to the bathroom or go down and get something from vending machines, that's fine, and then I'll see you back then, because that's when I'm going to start the lecture, around 20 after. And then if we don't have time for you guys to do your presentations,